Can we tailor MS treatment to minimize disease progression? Welcome, dear colleagues, to this virtual symposium. My name is Heinz Windler. I'm professor of neurology and head of the Department of Neurology at the University of Münster. I'm very pleased here to welcome you to this Roche-sponsored satellite symposium at the 28th Annual Charcot Meeting 2020. Giving you more details on the aspect of personalized or stratified treatment with regard to the minimization of disease progression. And I'm joined by my colleagues Wallace Brownlee, who is the clinical lead at the National Hospital for Neurology and Neurosurgery in London, and Klaus Schmierer, who is professor of neurology at the Blizzard Institute, also in London. Over the next 45 minutes, we will explore three key themes. Dr. Brownlee will talk about predicting MS disease progression to the individual. I'll then move on to discuss what might forecast response to treatment both and now in the future. And finally, Klaus Schmierer will consider the question what personalized therapy prevent progression and whether this will work. Please see here our disclosures, and please see the product disclaimers. Our welcome letter, which provides further information on today's session, can be found via the digital meeting booklet. Please feel free to submit any and all questions that you may have throughout our presentations. And finally, keep an eye out for two polling questions following our final talk, which we will then hand over and lead over to our faculty Q&A. We hope that you enjoy our symposium and find the discussion relevant for your practice. I'll now hand over to Dr. Brownlee, who will give his talk about how can we better predict patient prognosis in multiple sclerosis. Floor is yours.
Okay, well, thank you very much to Heinz for the introduction, and thank you to the organisers for asking me to speak on this topic. So we all know that, at least for people with relapsing multiple sclerosis, the clinical course can be very heterogeneous, and there's no real one-size-fits-all approach to how we should be managing MS. The varied long-term prognosis of people with relapsing MS was shown in this long-term follow-up study from here at Queen Square, shown on the right, where we looked at disability status for people who'd been followed from disease onset at the time of presentation with the CIS and went on to develop MS over the follow-up period. And we looked at their disability measured here using the EDSS score. And you can see that while many people in this predominantly untreated cohort had mild or moderate disability in the longer term, that there was a real range. And every step of the EDSS score was represented at 15 years. And I think this really demonstrates the marked disease course heterogeneity that we see in people with MS and the importance of trying to determine prognosis at an individual level to try and optimize patient care and personalized treatment plans. And just to give you an example of how we might approach this in clinical practice, this is a patient I saw a couple of months ago. She's 27 and has recently been diagnosed with relapsing MS. She initially presented with left optic neuritis with painful loss of vision in the left eye and had signs of a left optic neuropathy. We worked her up with an MRI scan of the optic nerves, brain and spinal cord that showed changes consistent with MS. She had a lumbar puncture that showed IgG oligoclonal bands that were unmatched, and for her age, an elevated CSF neurofilament. Her symptoms improved over a few weeks without any specific treatment, and she came to clinic to discuss treatment options. Before thinking about these options, I think it's helpful to try and look at the prognostic profile for this individual patient and how we might be able to personalize treatment decisions in her particular case. So starting with MRI, we're all aware that brain MRI is the key prognostic tool for determining the risk of multiple sclerosis in people with a first demyelinating episode. And T2 brain lesion load is also helpful in predicting long-term prognosis. So in a follow-up of the impressively large Barcelona CIS cohort, people who had 10 or more T2 lesions in the brain at the time of presentation were nearly 3 times as likely to reach EDSS-3 during follow-up. The problem with brain lesions is that they can be rather non-specific, and the relationship with long-term disability is only moderate. And looking at the location of lesions can provide more detailed information. For example, looking for lesions in the spinal cord can give important insights into long-term prognosis. The presence of cord lesions in people with their first symptoms of MS are associated with an increased risk of physical disability in the longer term, and also associated with a shorter time to onset of secondary progressive MS. So I think a spinal cord MRI, even in people without spinal cord symptoms, can provide really useful prognostic information. As part of the diagnostic process, we commonly do a lumbar puncture, and I think we're doing an increasing number of lumbar punctures with the most recent revisions to the McDonald criteria. And irrespective of the brain or spinal cord MRI findings, the presence of IgG oligoclonal bands has been associated with a higher risk for disability progression in the future. And this risk may be higher in people with IgM oligoclonal bands, which are an area of active interest. If you're doing a diagnostic lumbar puncture, another thing that you can get a free look at, potentially, if it's offered in your lab, is a CSF neurofilament level. Neurofilament in the CSF may be elevated and be associated with an increased risk of disability progression in the future. And certainly in our patient, she had an elevated CSF neurofilament for her age. One of the difficulties with the CSF, of course, is that you may do a CSF around the time of diagnosis, but it can be difficult to convince patients to have repeated lumbar punctures. And so there's much more interest, I think, in serum neurofilament, which remains a very hot topic in MS. Serum neurofilament may be an important prognostic tool, and elevated levels of neurofilament in the serum, particularly at percentiles greater than 95th percentile compared with the healthy population, is associated with an increased risk of EDSS worsening over time. This is something to look out for that hopefully we'll be able to enter our clinical practice in coming years as a marker of prognosis and of treatment response in people with MS. So what else can we do when we look at the patient's history to help gauge their long-term prognosis? Well, if we look beyond MRI and CSF, there are other insights to be gained. So, for example, in our patient, she had low serum levels of vitamin D, she was a smoker, and she had a history of treated depression. And so the question is, what impact do environmental factors and comorbidities have on long-term disease course? Starting with smoking, we know that smoking in MS is bad. Smoking is associated with an increased risk of MS, but also in established MS is associated with increased evidence of inflammatory disease activity, faster rates of brain atrophy, and a shorter time to conversion to secondary progressive disease. Smoking may also be associated with response to disease-modifying therapies, and in this study, people who smoked 20 cigarettes per day who were treated with natalizumab had a 38% higher relapse rate than people who didn't smoke. Vitamin D, like smoking, is also associated with multiple sclerosis susceptibility and may also be a prognostic factor. People with lower levels of vitamin D may have higher levels of inflammatory disease activity. That's been shown in the BENEFIT study, a randomized trial of interferon beta 1b versus placebo in patients with their first symptoms of MS. And this may also be a risk factor for increased disability progression. Interestingly, in the recently completed 11-year follow-up of the BENEFIT study, people who had higher levels of vitamin D over the first few years after the onset of MS, that was associated with a lower serum neurofilament level at the 11-year mark. And that may indicate a relationship between vitamin D and neuroaxonal loss in the brain. In terms of comorbidities, this patient had depression, and depression has been associated with a delay in MS diagnosis and a greater severity of disease when MS is diagnosed. But even when you put those aside and account for those delays in diagnosis that are common in people with a history of depression, depression itself is associated with a greater risk of disability progression over time and increased healthcare utilization. And thinking about comorbidities and including them in our prognostic profiling of patients with recently diagnosed MS is essential. And I think as neurologists, this is something that perhaps we're not so good at. So coming back to our patient, I've shown you how we might integrate clinical, demographic, imaging, and biological tools to provide an individualized approach to prognosis. But what else do we need, or where are the challenges for the future? And I think key among these is our inability at the moment to really phenotype patients for evidence of the extent of neurodegeneration at the time of diagnosis. And we know that neurodegeneration and axonal loss over time is one of the key predictors of worsening disability and progression in MS. And that was very nicely shown in the study of over 1,000 patients with different MS phenotypes who were gathered as part of the Magnum's collaboration. And deep grey matter volume at baseline, and particularly thalamic volume, in people who had a lower deep grey matter volume, the risk of disability progression and worsening disability over time was higher in this group. The challenge is, or the difficulty that we face in clinical practice, trying to assess deep grey matter or thalamic volume in patients that we see in the clinic is not straightforward. And there's a challenge ahead to try and translate these advanced MRI measures that might give us insights into the extent of neurodegeneration into the clinic. And finally, just a comment on genetics. So we know that there are a large number of risk alleles for MS that influence MS susceptibility, but what's less clear is how genetic factors impact on the severity of MS or MS progression over time. Cross-sectional studies have produced conflicting results as to whether HLA-DRB1 1501, the most important genetic factor conferring MS susceptibility, whether that has any impact on the phenotype of MS. But I think this longitudinal study in people with primary progressive MS, published a couple of years ago, was interesting in that it showed that people who carried the HLA-DRB1 1501 allele had a greater extent of inflammatory disease activity and a greater extent of tissue damage in the brain as measured by MTR. So I think in the future, we'll be able to use advanced MRI measures to better phenotype our patients and hopefully have better insights into the impact of genetic factors to help determine individual prognosis and personalized treatment plans. So thank you for your attention. I'm going to hand back over to Heinz, who's going to try and forecast response to treatment, both now and in the future, in our patients with MS.
Yeah, dear Wallace, dear Dr. Brownlee, thanks for this kind introduction. Handing over to my talk, what might forecast response to treatment both now and in the future. Let me start with a visualization of treatment approaches. So in a traditional way, we're using more or less different products roughly over a heterogeneous crowd of MS patients, while in the ideal world of a personalized approach, we would specify the pros and cons and the ideal combination in a patient individual way. Where we are at the moment is probably a stratified approach. We have certain strata in some of the dimensions we are weighing and balancing against it, and the key dimensions will pop up in the next slide. It's the trajectories we're talking about in terms of efficacy, safety, and some sort of individual factors that add to the complete picture. I think when discussing about how to best manage a patient through the long-term journey, we definitely should not ignore long-term efficacy, but we definitely have to consider safety and practicality very top on the list. And we have to, and this is going into the direction of personalization or individualization, individual factors. Let's go through some examples of why this is so important, because in the end of the day, it's a treatment concept that we are believing to follow more than some very product-specific consideration. This is a key slide from a very important publication that has been reported in 2019, which provided evidence that is accumulating from all different sorts of data repositories, but here a industry independent one, that the initiation of a higher efficacy treatment early on is associated with a long-term win. And that is one of the silver bullet question in the field, to say, well, if I start slow and moderately and wait until the disease becomes as bad as I think it might become or might not become, is this equally well as a strategy to say, well, let's always try to achieve best possible disease control from the very beginning? And here the endpoint was risk of conversion to secondary progressive MS, and the significant difference between those that start with a higher efficacy therapy as opposite to a moderate or lower efficacy therapy was in favor of the strategy to go strong rather early. The other question is whether you can recover, or you can regain what you have lost in initiating a certain treatment concept later on. And this is exactly shown here as data from the ocrelizumab study program, that patients that start after having received interferon therapy on a higher disability level, they remain on a higher disability level. And the difference to the ocrelizumab group, they could not be regained. So that means what is lost is not regained. Every damage to the central nervous system is a potentially irreversible one. Let's go to the second aspect, which I find particularly meaningful with regard to the simple question: if all therapies were super safe, there were no real arguments not to go for the more and most effective ones. And the field has taught us several lessons over the last years, that safety in especially a lifelong disease, which requires very long and ongoing therapeutic interventions, is key. We have to find best monitoring measures and tools, and we have to provide patients with therapeutic approaches that remain doable in terms of tolerability and feasibility. That actually guarantees best possible adherence to the therapeutic concept. A very famous example in terms of risk stratification comes from natalizumab, which is efficiently blocking leukocyte traffic from outside in, but in the end is associated to a very rare opportunistic disease. And depending on the duration of treatment, this risk can go up. And JC antibody status has developed itself as a very meaningful stratifier to make this decision point in patients with JC antibody positivity. Natalizumab is definitely more risky and maybe not the ideal choice. Similarly, with the oral compound dimethyl fumarate, which lowers lymphocyte counts in a low percentage of patients, but relevantly, this threshold and monitoring requirement is implemented as a measure of risk mitigation on the long run. And lately, a first example in the MS field has introduced itself, implicating that a genetic equipment in metabolizing enzymes here with a CYP2C9 machinery is predefining the likelihood how the S1P modulator siponimod is metabolized. And that actually is decisive for the dosage or the go-no-go decision, whether this patient can receive the drug, which is the case in approximately 0.1 to 1% of the population. For B-cell depletion with ocrelizumab, B cells generate plasma cells. Those produce immunoglobulins. The question of the lowering of immunoglobulins on the long run was keenly associated to the question of, is this risky over many years? And this is shown here, that most of the patient, much more than 90%, remain with their immunoglobulin levels over the lower limit of normal, despite some decrease in immunoglobulin levels, that doesn't seem to be a major risk factor in the overall treated population. Yeah, let's come to the third aspect, individual factors. I was already touching briefly upon the genetic equipment that we have, and there is a need for genomic markers that we could use in terms of predicting likelihood of success or appropriate dosage regimen in MS treatments. And there is an interesting example out of the B cell world. Rituximab, one very established B cell depleting antibody in the field, has been shown to depend in terms of its efficacy on certain genetic predeterminants. And here it's FCG receptor polymorphism that can influence efficacy because of its relative direction towards how B cells are depleted and eliminated. And from the rheumatoid arthritis field, there has been an association to efficacy with a certain polymorphism here, VV homozygosity. That means that the more effective the treatment is depleting B cells, which is a consequence of this pharmacogenomic marker, the higher the likelihood of a clinical efficacy is provided. And last but not least, we have patient individual factors that we now know can interfere with therapeutic concepts or with the individual disease course. And one very prominent and certainly avoidable one is smoking. Smoking is associated with higher disease activity. The odds ratio is not unrelevant. And this is a clear recommendation we have and give our patients at disease initiation or while being on a disease monitoring endeavor. The other is body mass index. That's body weight in relation to body size. And what we know is that body mass index per se is a risk factor for disease activity and severity. So more heavy-weighted patients are at a higher risk to acquire disability, in addition to the independent effect of a dose relationship to body weight, which we have observed in a couple of treatments that are not body weight adjusted. They are just a fixed dose, and they obviously can make a difference in terms of risk and also efficacy in the patient population. So what we would like to achieve is, and that is established meanwhile, a NIDA status, no evidence of disease activity in our patients, and those factors that I just touched on, smoking and body mass index, are clearly associated to this. Let me close with showing this visual again, where we are and where we would like to go. I think we have provided a couple of examples and prominent examples why a stratification of treatment approaches is lived reality. And I think we're on our way to really personalize more and more these treatment strategies based on solid scientific evidence and integrating patient individual factors to, in the end, close the gap between the traditional approach and the personalized approach. And with thanking for your attention, I'm handing over to my colleague Klaus Schmierer, who will inform us about whether these personalized treatment concepts in the end have an impact on preventing disability progression and disease worsening.
So thank you, Heinz, for your presentation on building this lovely bridge at the end of it to my talk entitled Will Personalized Therapy Prevent Progression? And I brought you a slightly dry definition here, but fundamentally, personalized therapy is obviously a medical model that stratifies people into different groups with medical decisions, practices, interventions, and or products being tailored to the individual patient based on their predicted response or risk of disease. Now, In the previous presentations, we've explored prediction of disease cause and treatment response. But what else do we need to in order to move towards personalized healthcare, if we can do that in multiple sclerosis? What enables us to call our approach indeed personalized? Now, personalized medicine could have some significant benefits. So there's a global recognition of the potential benefits of personalized medicine with multiple healthcare systems, including US and Germany, Australia, having sort of formulated policies and research programs around this topic. And it may have advantages, obviously, in preserving a neurological function, through accelerated diagnosis, may optimize the response to therapy by targeting specific aspects of the disease. You may even think about disease prevention, so by treating the underlying cause or minimizing risk factors, and of course advancing biomarkers and risk to identify risk as early as possible. So there's a number of challenges to overcome in order to move towards personalized medicine. We've talked about one in previous talks, that's about biomarkers of MS susceptibility and prognosis and treatment response. So I'll leave that out here and rather focus on advancing treatment options and developing clinically meaningful measures, which we should ideally be able to implement really in and outside of clinics, obviously in the current situation, particularly under the pandemic. There's a wide range of treatments that, or a wider range of treatments that now provide safe and effective options for some patients, including BTK inhibitors, which are small molecules inhibiting both B cells and myeloid lineage cell activation, and potentially plasmablasts and plasma cells. And this may offer a novel approach to suppress disease activity and slow disease progression by targeting the acute and chronic inflammatory response in MS. And fenebrutinib is the one candidate here, which is the only non-covalent reversible BTK inhibitor in phase 3, and there are others, also, or several large manufacturers have their own product in the pipeline there. One topic quite close to my heart is looking at combination therapies, and you can first of all think of remyelination or facilitating remyelination. There have been various attempts to do that. It's not quite straightforward, as we found out, for example, with opicinumab, a program that has been stopped by now, and more recently the bexarotene study that in Cambridge, a small study that was also negative on the primary outcome. So it's a really interesting and yet also challenging territory. Other studies are underway that have shown promise in phase 2. Simvastatin is a large program underway at the moment in the UK, a phase 3 trial of this in progressive MS, secondary progressive MS. And supplementary therapies such as sodium channel blockers have also been explored, for example, phenytoin as an add-on to steroids in optic neuritis, awaiting confirmation really, and hopefully a phase 3, maybe with a different sodium channel modulator. So clinically meaningful measures of disease progression are needed to improve patient care. I think that's quite clear. So we need to find ways to relate the implications of treatment response to patients' daily life. There are quite straightforward and simple measures such as time to walking aid that are quite intuitive for patients, and this increased understanding may also help and facilitate self-management. So the question is, how can we capture this using simple tools, data sharing and patient engagement, particularly in the current climate? And here's an example from our own practice at Barts that we've been developing for some time that obviously puts the person with MS at the center, that feeds in their PROMs, their patient-recorded or reported outcome measures into the portal, and including several questionnaires. We obtain what we call a 3-test, which includes the SDMT, the 9-hole peg test, and 25-foot walking test, which is in the past collected at their outpatient consultation. Now we've started doing these remotely as well, which are then fed into both our electronic record as well as in our database, which then feeds back into the register, so that it becomes essentially a research tool, and at the same time a clinical monitoring or element of clinical monitoring in clinical practice. Times move on, and there are obviously now apps that also try to capture the information of patients' condition. And here's the example of the Floodlight app that focuses on various aspects of the condition. Here's hand function, so there's the pinch of tomato and draw a shape test. There's gait and balance involved with a U-turn test, a cognitive test, and daily mood and symptom tracker. This is one of several options. You may have heard of IcoBrain, for example, as a further alternative, which I think have great promise as long as they're being well validated and adopted by patients in their daily life. The Clinic Speak website, with particularly my colleague Gavin Giovannoni, has led on this to enable patients to assess themselves. So here's the EDSS, which is a web EDSS tool based on the telephone EDSS that many of you will know from clinical trials in the past. Ludwig Kapphaus has sort of led on that. The nano peg test using a cardboard version that we can send out, and the time 25-foot walking test. And then always important and also to produce the results so that people can actually assess in a way themselves how they're doing and engage in the discussion of their treatment and management. So it really allows a kind of a tailored approach, increases the understanding, which empowers patients to implement that in the interaction, as it were, with their healthcare professionals, and hopefully we'll be more sensitive to subtle changes that may indicate disease activity and leads us to responding to that. The team is of crucial importance, and it must be or should be a multidisciplinary one. You can see all the disciplines here that we're collaborating with, we're referring patients to, that are important, that can all provide information to tailor individual patients' care. And it's obviously never wrong to listen to patients themselves as a resource of information about their disease. So will we have a greater impact on progression by applying a personalized treatment approach? I think that's a matter for the discussion. And here's really examples of both sides of the coin debate. So increasing individuals' control over their own health also involves increasing responsibility, potentially, which in turn can easily translate into heightened expectations or even obligations around maintaining and promoting personal health. And with this, I hand over to the Q&A session, which follows next.
colleagues, I'm not sure whether everybody can hear me now. So we're going live, and I'm just asking my colleagues whether I can be seen and heard. First of all, thanks to colleagues for these beautiful talks and the insights into the topic. I have a couple of questions.
Excuse me, Mr. Windel. You are not using the correct microphone input.
Show them to the audience and look how the responses work. And I've already seen a couple of questions that were directly addressed to us that we can go through afterwards.
Yes, I think, hello, everybody. I believe that Heinz's or Professor Windel's microphone is not really operational. And I did find a question here that came in from Dr. Brownlee, who really flagged the importance of cord lesions in his talk as a predictive factor. And the question is here whether what do you recommend in terms of follow-up? Is there, do you recommend including cord MRI in the regular follow-up? That is the question.
So I think that's a great question, Klaus, and I think that is an area of uncertainty. And there's remarkably little evidence actually to guide us as to what the value of cord imaging is in this situation. There was some nice work from Switzerland showing that perhaps about 10% of patients who have stable brain MRI may have an asymptomatic cord lesion that you can pick up on a follow-up MRI scan. But that's a relatively small number, and many of the patients in that study were on low efficacy disease-modifying therapies like the injectable agents. I think in our practice, we don't routinely do spinal cord imaging, and it's something that we need further evidence to guide us on. I think the value is probably particularly low in people that are on a high efficacy treatment where we very rarely see new MRI activity.
I think Professor Klaus's connection is dropped. So
I'm the last man standing then. So Heinz and Klaus are having technical issues. Is that right?
yes, that's correct.
Okay.
Is he reconnecting, I suppose?
I think there are another couple of questions in the chat. Should I, perhaps if we move on to some other questions?
Okay.
Or we have some polls that we could run as well. Why don't we go to the polling before we start the questions? Are we able to take that forward? So first question for everyone. Which of the following options do you think requires the most improvement in order to move us closer to personalised medicine? So would you say it's developing clinically meaningful measures of disease progression, implementing disease monitoring outside of clinic visits, as we heard a little bit about from Klaus, advancing treatment options with different mechanisms of action from what we have at the moment, or do we need biomarkers of MS susceptibility and therapeutic response? So we'll be interested in your answers to those questions. And if we get the rest of the panel back on, we can hear some views other than my own. Oh, I think we've got Heinz. Yes. Heinz, welcome back.
I'm back on after completely restarting the thing, but it was an interference, obviously, with my iPhone and the program. So the program otherwise works excellent. So no blame on anybody, but there was an interference. I should have completely shut down anything that would disturb me. So I'm back. I hope you can hear me and see me. And thanks for jumping in, Wallace.
That's okay. So I think we were going to leave people to vote on the polls. So hopefully we'll have all the votes in now. And so this is how you voted. So I think that that we probably, or 3/4 of you feel that identifying biomarkers of susceptibility, prognosis, and therapeutic response are tremendously important. And I think one of the ones that I was interested in, Heinz, from your presentation was around this genotyping of patients with rheumatoid arthritis and the impact on response to rituximab. Do you think that that's something that might be investigated in multiple sclerosis in response to B-cell therapies?
I think yes. Fc gamma R polymorphisms are of interest for all immune-depleting antibodies. We have done that for alemtuzumab. That didn't show any real difference, but the cohort was pretty small, and we're intending to do that also for ocrelizumab, which has a little bit another depleting mechanism than Rituxan, but it's definitely worthwhile. And you know that there is data that show that the level of B cells, even if it's anyway extremely low following ocrelizumab, might nonetheless be associated to a better or worse response in terms of NIDA after ocrelizumab. I think there is still ways to really better individualize and measure what we're doing.
Absolutely. Now, I think there were one or two other questions, or we may have another poll. I'll hand back over to you, Heinz, to take things from here.
Thanks again, Wallace. So let's continue with the polling question. So do you agree that a personalized treatment approach will have greater impact on disease progression versus the classical ubiquitous approach? I think this is a key question for our symposium, and I would like to ask for your intuition, knowing where we are and what is still our major gaps. Yeah, please vote. It's either a yes or a no or a not sure. Yeah, the sentiment goes towards definitely what I think the symposium intended. We need to be more personalized or individualized or stratified, and the given examples already point towards this direction. Clearly, we are not as good as we should be, but even with approaches that you could consider one size fits it all, as in the earlier days everybody got interferons, they are not as such, because I mean, and that is one of the questions, I'm not sure whether you have already talked about that came out of the audience. How and when and what could predict responders from non-responders? I'm just reading this here, especially when considering the choice of B-cell depletion versus cladribine. So what would be responder versus non-responder criteria, clinical, paraclinical, or predictors? Can I hand that over to you, Wallace, whether you have an idea here?
I think this is a very difficult area, of course, and I don't think we have any really robust data to guide us as to who's going to respond better to one high efficacy treatment than the other. And just like with genotype for B-cell therapies, I think that maybe polymorphisms may be important in response to cladribine. You know, we see occasional patients who you dose with cladribine and there's no measurable pharmacodynamic effect on their lymphocyte counts, and you wonder how those people are going to respond in the longer term. I think there's a great deal of uncertainty here.
Yeah. There is a question coming from the audience that I'm, in addition, throwing into our faculty. Very practical one. Is it possible or conceivable for a patient with EDSS 5.5, so already pretty disabled, with a non-active progressive course, call it SPMS, to go from interference to B-cell therapy? So switching from interference to B-cell therapy, is there a case to be made here?
Gosh, that's a difficult question, and I would like to, in an ideal world, I'd like to randomize this person into a clinical trial to compare what would happen if we escalate their treatment, because I think we don't have strong evidence that escalating treatment in patients who don't have evidence of active inflammatory disease is beneficial. So if this patient is relapse-free and doesn't have any changes on their MRI scan, then I think this is an area free of evidence as to whether there's a benefit to escalating treatment. I think that one thing that could be useful would be to look hard for measures of disease activity. So you might want to consider imaging the spinal cord as well as the brain if it hasn't been done recently. And I think a neurofilament might be quite helpful in this situation too. Say you've got a stable MRI scan, but the neurofilament is elevated in this young person, then you may be encouraged to make a switch in their therapy. But this isn't something we would do routinely in the UK to escalate treatment on the basis of progressive disability alone.
I would add.
Okay, just some information. In 1.5 minutes, we will start the next session. So just to inform you. Thank you.
Maybe just one final sentence to this question of escalation. I think one decision point is to say yes or no. The other decision point is to end such a therapy, given the fact or the knowledge that it didn't really help so much. So given the benefit of the doubt, we're once in a while doing this, but we're agreeing with the patient what are our goals. So if it worsens over 1 year or 2 years, we then again stop, but maybe give it the chance or the option, but define stop criteria. I think that is an important message. And I think we're close to coming to the end of this symposium, and I'm thanking you that you listened, albeit this is still a somewhat new reality format, but I'm thanking my faculty members, Wallace and Klaus, for doing this together with me. It was a lot of fun, and I have to say the result looked quite professional. And I wish you all a very good rest of this Charcot Foundation, hopefully next year again, face-to-face in Baveno. Thanks, and have a nice rest of your day and evening and the conference.